treatment, even when we present the impact work. All right, Kirstie. She's going to present some work that we did in Zambia.
Good morning, everyone. I'm presenting today on behalf of one of my colleagues in Zambia who's been managing this work in country. And I'm going to be describing some preliminary findings from an operational research study that we've done, which has been working alongside the ICCM implementation in Zambia that Helen described this morning. The study is exploring the factors which determine rational use of antibiotics, specifically in relation to pneumonia at community level. So just to give you a little bit of background, worldwide, pneumonia is the leading cause of death in children, and it's responsible for approximately 1.2 million deaths of children under 5 each year. In Zambia specifically, in 2010, 14% of mortality of children under 5 was due to pneumonia, which is equal to about 6,700 deaths. So ICCM has great potential to reduce the burden of pneumonia, especially in hard-to-reach populations. However, increasing levels of antibiotic resistance is of concern globally. Community health workers offer the opportunity to improve the rational use of antibiotics, as community health workers involved in ICCM are trained, supervised and supported. And this is in comparison to perhaps using private providers, which are difficult to regulate, so people will be accessing treatment through them on a normal basis. However, evidence is limited. We're exploring this issue in Zambia to ensure that we minimise resistance and maximise access to treatment. So the aim of this study was to provide evidence on the rational use of antibiotics at the community level to inform further implementation of ICCM. We have 6 specific objectives for the study, but they're all related to understanding the factors that influence rational prescription and antibiotic use for management of pneumonia at community level. This work was jointly funded by CEDA and also COMDIS-HSD, which is a UK-funded research programme consortium. And this is an example of where Malaria Consortium is embedding research onto its implementation. So the study took place in Zambia, in the Luapula province, where we were implementing ICCM, and in 2 specific districts, Kawambwa and Samfya. It's a cross-sectional, mixed method study using both quantitative and qualitative aspects. There's 3 components of the study. The first is looking at observation of community health worker consultations. And this was to determine if community health workers could correctly identify, test and prescribe for suspected pneumonia patients. Now, our observations also included using a video to record the community health worker measuring the respiratory rate. This is quite different to other studies which have observed consultations or have monitored the use of community health workers measuring their respiratory rate, where the community health worker was taken into a health facility to assess their ability to measure respiratory rate. The second component was a follow-up of all caregivers whose children were prescribed antibiotics during the observation period to determine adherence. And thirdly, focus group discussions and key informant interviews with community health workers and caregivers. And this was to determine influences in rational prescription and the behaviour and attitudes of the communities towards the health workers and what medicines were prescribed. So the data collected, just to give you an idea of the scope of the study and all the data that we collected, we followed up 56 caregivers, and this was conducted on the 6th day after they were prescribed antibiotics. So antibiotics, the course of antibiotics given for pneumonia at community level is 5 days. So we followed up on the 6th day after they were given antibiotics. We observed nearly 1,500 community health worker consultations over a period of 6 weeks. This involved 90 community health workers who were each observed for 2 days. And then through these consultations, we had about 700 videos of respiratory rates recorded. These have since been independently measured and verified by IMCI, ICCM master trainers identified by the Child Health Unit of the Ministry of Health in Zambia, and they did this in pairs. And we've also did 9 key informant interviews with community health workers and 6 focus groups with community health workers and caregivers. So today I'm just going to present the preliminary findings from one aspect of this study, which is the community health worker observations. So of the 700 videos that we took, only 538 were included in the analysis. Those that were excluded were due to poor video quality, missing information, or if the child was unstable, crying, or breastfeeding. The mean number of observations per community health worker was 166. The mean age of participants was just over 2 years. And there was approximately an equal number of male and female children that were observed through these consultations. So first of all, we have analysed the comparison of all the respiratory rate counts that were taken. And this graph shows you that the percentage of children diagnosed with fast breathing by the community health worker and the expert is quite similar across the 2 age groups. Analysing this further, about 68% of the community health worker counts that were taken were within 5 breaths of the expert count, and 54% were within 3 breaths of the expert count. But there was no significant difference between the expert and the community health worker respiratory counts. So subsequently, looking at the classification of fast and normal breathing, so this is precisely looking at the cut-offs at which a child would be classified as fast breathing, and looking at the ability of the community health worker to classify children correctly compared to the expert. So the cut-offs for fast breathing to diagnose pneumonia for the age group 2 to 11 months is greater or equal to 50 breaths per minute. For 1 to 5 years, it's greater than 40 breaths per minute. So using Cohen's kappa test, we found that there was a strong agreement between the community health worker and expert classification. And looking at sensitivity and specificity, which is the ability of the community health worker to correctly classify those children with fast breathing, and specificity is the ability of the community health worker to correctly classify those who had normal breathing and not give them antibiotics. And these were found to be high. So looking at community health worker adherence to the ICCM guidelines in the prescription of antibiotics. So overall, in the whole study, 202 children were prescribed antibiotics. 170 of these, or 84%, were correctly prescribed according to community health worker defined fast breathing. Between the age group 2 to 11 months, about 89% were correctly prescribed, and 1 to 5 years, 80% was correctly prescribed. And we found that there was a significant association between the child having fast breathing, as assessed by the community health worker, and them receiving amoxicillin. So looking at this in a bit more detail, as per the community health worker assessment, 90% of children received appropriate treatment for their condition. So this includes those with fast breathing receiving an antibiotic, but also those with normal breathing not receiving treatment. And of all the children with fast breathing, 89% received an antibiotic, overall showing that they had very good adherence to the guidance or the guidelines that they're given. So looking at the correct dose of antibiotics prescribed, so Helen talked earlier about how we had age-specific formulations of drugs, and these came in different coloured packs in Zambia. And so we found that 17 of the older children received the lower dose of amoxicillin, so potentially were underdosed. However, we're looking and doing further analysis at the moment on those numbers to determine the exact age of those older children, whether they were quite close to the cutoff at which they should have received the higher dose of amoxicillin. Yeah, so we're just looking at the age of those children specifically. And only 3 of the younger children received the higher dose of amoxicillin intended for older children. So this is now looking at appropriate treatment received based on the expert assessment of the respiratory count and the gold standard. So 78% of children received appropriate treatment for their condition. So that's those with fast breathing as defined by the expert receiving an antibiotic, and also those with normal breathing not receiving an antibiotic. And of all the children with fast breathing, 75% received an antibiotic. So overall, a high number of children were appropriately treated. Now, the learning from this study so far, we've got more quantitative and qualitative analysis to do, but we found no significant difference between the expert and the community health worker respiratory count. There was strong agreement between the community health worker and the expert classification of fast breathing. The majority of children who required antibiotics received them, and inappropriate use of antibiotics was minimal. Thank you.
All right, thank you very much, Kirstie. Maybe I'll just go to Teresa to find out if she has a follow-up question from the previous one she asked before we go on to the next presenter. Yes.
Some of the problems that we noted had to do with the timer, and you didn't tell us what kind of timer was being used. That can cause a problem with the respiratory count. And the second thing that actually, in some of the research that I've been doing, the facility provider does a worse job than the community health worker, often just throwing 2 treatments at the child. The child comes in with fever, fast breathing, let's treat him for malaria and pneumonia. So I was wondering if you looked at whether or not they were being provided with dual treatment or not.
Okay. In terms of the timer, it was a UNICEF timer. So it's I did show a picture of it. It's the black one with the, in terms of the second question, we didn't specifically look at that within the quantitative aspect of the study, but I think some of the qualitative data that we're analysing at the moment will kind of begin to address that question. There's quite a lot of discussion in the qualitative data about appropriate referral, and caregivers would say that they would take their referral letter or referral card to the health facility, and they would then be treated according to what the community health worker had said. They would be checked, but it would agree with what the community health worker had said. So from the qualitative data so far, it looks like there's really good links between the community health worker and the health facility worker, and that they really work together on treating these appropriately.
Okay, any questions from the chat room? Okay, all right. Sorry, the lady from MSF. Yep.
Thank you. It's not directly related to the presentation, but what did you do with children? We know with so many experts with practical experience to get it. With the children that vomited, because we have these pre-packaged malaria drugs now, and you had pre-packaged amoxicillin. What if children vomited on the spot there? How could you give them an extra treatment? How did you manage that, either for pneumonia or for malaria?
Okay, James, do you want to say something about that?
They are instructed, the community health workers, that when a child vomits within a particular specific time, particularly also for the SCTs, and the company will tell you if a child is vomiting within 15 minutes or so, you will repeat the same dose. And the community health workers are aware of that, and they really tell the caregiver that if your child vomits within a particular time, give another dose, because definitely that shows that the child did not take the medicine. That now goes back to the supply chain, because that's what the community health worker will report as loose tablets or lost tablets, because that pack has now lost a variable, maybe two tablets of the yellow pack that was supposed to be given. So they have been trained, and are aware of that, and if a child vomits, which normal happens, within a particular period of time, repeat the same dose. And if the vomiting continue, then this warranted to be coming back to me and then getting a referral note, a card, to another level for further management. So they are aware of what to do in terms of vomiting.
Okay, thank you. Sorry, the gentleman from Save the Children, and then we'll go on to the next presentation.
Thanks. I think someone mentioned already, but I think it would be very useful to compare the diagnosis, so sensitivity or specificity of diagnosis of pneumonia with the health workers based in health facilities in the same setting. So you talked about 78% accurately diagnosing or treating. In Zambia, it would be useful to know what other professional health workers are doing. I think related to that, what is the optimum percentage of so adherence to treatment protocols? When we say it's good, 78% is good, how good is good? Or how do you define good? So what percentage is what we're looking for? And I think it would be good to have that sort of a scale in terms of what's good and what's very good. You didn't really mention adherence to treatment at the community level, at the household level. So even if the treatment was provided at the time by the community health worker, what happened for the next 5 days? Did the mothers complete those treatments?
Yeah.
So it would be good to know course completion rates and stuff. Thanks.
In terms of caregiver adherence, that data is still being analysed, but we have collected. We interviewed the caregivers, but we also asked to see the packs of drugs that were given to see how many were left, or if any. And we've asked questions in the focus groups as well with the caregivers on their views about adhering to treatment and whether they would perhaps share their treatment with other kids. So we'll be able to answer that at a later date, I'm afraid.
Yep. Okay. All right. I think thanks for those observations and comments. I'm sure at some point Novartis will want to say something about the effectiveness of AL